I think we have to understand that microscopic blood in the urine is very common. Anywhere from 10 to 15% of adults will at some point in their life have microscopic blood. And so the burden of disease is extremely high. The AUA guidelines have tried to help stratify patients based on risk and then make recommendations regarding how extensive an evaluation you should have. But the guidelines from 2020 still recommended cystoscopy for the vast majority of patients with microscopic blood, including men over the age of 40. And that is based on the concern for finding cancer in the lining of the urinary tract or kidney cancer. And of course, there are other causes, problems with the prostate, urethra, potentially kidney stones, etc. Cystoscopy specifically, though, is mostly to look at abnormalities within the lower urinary tract. However, they are invasive procedures, and many primary care physicians never referred patients for any evaluation whatsoever. So the rationale for the Strata trial was to see whether or not using a urine marker with a high negative predictive value in patients who are on the lower risk of the spectrum might reduce the number of patients who needed cystoscopy and may eventually increase the number of patients getting evaluated and still allow for evaluation of higher risk patients if they had a positive urine marker. I think we have to start off with the fact that this was the first randomized trial trying to use a urine marker in an algorithm that evaluated patients with microscopic blood in the urine, and try to use some rational or practical approaches to see if we can reduce cystoscopy. This is not yet guideline recommended, and so the impact on adherence to guidelines and clinical practice is yet to be determined. However, I think it is encouraging that patients without a marker were not found to have cancer, with the exception of one patient who a year later actually had a positive marker, and maybe they developed that cancer subsequent to the initial evaluation. But nonetheless, the hope is that primary care physicians eventually, consider adopting strategies, one, to evaluate the higher risk patients and follow the guidelines, and two, we have to see whether or not the guidelines change to, incorporate urine markers in a diagnostic algorithm, and then likely we'll be able to see some changes in practice. Well, there are two factors in incorporating a marker. First of all, is it accurate in identifying the disease or absence of disease? And so the 99% negative predictive value is obviously reassuring. And in part, this is because in the low risk population, the risk of bladder cancer is 1% or less. So we're already starting with a situation where very few patients have bladder cancer, and adding on top of that a marker that can detect most high-grade and a fair number of low-grade cancers. I think, obviously, urologists should follow the guidelines, and we'll have to see if the guidelines incorporate these markers in an algorithm to evaluate patients. But I think with a marker with a very high negative predictive value, you're unlikely to miss cancer, and also it might reassure you that you could wait and recheck the urine maybe down the road, and if they have persistent blood, maybe then do an evaluation, and if they don't have further blood or new symptoms, maybe you don't have to do cystoscopy in all these patients.